tangible and discernible, indicating real change. So to start us off today are my colleagues and friends from Mowbray Maternity Hospital who are going to share their process of mentorship for neonatal medical officers. So I'm going to stop sharing so that my colleagues can actually share their screen and they'll take it over.
Thank you, Shakti. And I think our camera is also on, so you should be seeing my team and I. So I'm Dr. Natasha Roeder. I'm a neonatologist at Mowbray Maternity Hospital. And in the background, you'll soon meet the rest of the medical officers that will also be presenting. And we would just like to thank the faculty and certainly your transformation group, Shakti, for taking this forward for us. So I've got with me Dr. Michelle Groenewald, Dr. Leanne van Baarle, and Dr. Kele Kuluani. And we want to share with you our early successes with the plan that we instituted about 3 years ago. So just some context, Mowbray Maternity, for those of you who don't know, is almost now, she's a grand old lady. She's almost 110 years old, but she certainly serves quite a huge population. So currently we have about 10,000 deliveries in our drainage area, and we are, you can see the numbers there just to give some perspective, and we often see the unprepared patient from a clinical perspective. So we are hardworking with a core team, and the medical officers that we're talking about today are part of that core team. But we also like to refer to them as our invisible and our aspiring academics. And without any further ado, I'm going to allow you to hear their stories. So take it away. Can you see all of them? There they are.
Hi there, I'm Leanne van Baarle, a senior medical officer. I'm a married mother of 3 fur children. I, together with Michelle, run the Metro West neonatal outreach clinics. When I started at Mowbray in 2013, I was a community service medical officer, who after internship only had an interest in anesthetics and pediatrics, and Mowbray seemed like the perfect fit. I also celebrate my first decade at Mowbray this year. Since then, I've been at Mowbray because of the potential to grow my knowledge and skills in neonatology. After a couple of years, I had the opportunity to join the outreach team, and that is where I found my passion, my calling, and my niche. My goals were then to increase my own knowledge on general and community peds, and this is when I did my postgrad diploma in community and general peds at UCT. The goal from then was to improve the service which provided for the community and to become the link between primary level and secondary and tertiary level. I've also chaired the MOU Executive Support Committee twice, which provides oversight from the neonatal and obstetric services in Metro West, including MOUs, hospitals, EMS, and banks. While doing this, together with Michelle, we have been assisting Dr. Roeder as the 4th year convener in the perinatal health rotation we share with obstetrics by bringing our individual strengths to the 4th year program. My insights at community and primary care level neonatal care ensures that the curriculum content is aligned with the burden of disease within our community. The processes of becoming an honorary UCT lecturer has been daunting, but the award has validated our work and worth within the health system, especially at an academic level. To be recognized for this has certainly opened our eyes and minds to new opportunities within academia. I look forward to where this will take me in the future. I've absolutely grown at Mowbray in a way that I did not think was possible for a medical officer. I'm senior in my post, I do senior calls at Mowbray, and I love what I do. The plans for the future are to publish how anyone or any unit can start and run a successful outreach program so that the excellence we provide can be duplicated.
Thanks, Leanne. So I don't know if you can notice, but Leanne is camera shy, so it's a huge thing for her to actually be showing her face. So yeah, thanks, Leanne. So Michelle.
Thank you. So I'm Michelle Groenewald. I'm also one of the senior medical officers at Mowbray Maternity Hospital. I'm a married mom of 2 young kids, 5 and 8 years old. And I started at Mowbray in my community service year in 2014, where I fell in love with neonatology and the department that I got to work with. So I came back as a permanent MO in the year of 2015, and I haven't left yet. But when I started at Mowbray, I knew I loved neonates and was excited to work in the neonatology department again, but didn't have a clearly anticipated career path ahead. I knew I had an interest in clinical neonatology and community neonatology, and while I was here, I'd also sparked an interest in undergraduate teaching. So as I grew in my own experience and knowledge here, I also began to grow in my involvement in teaching, and slowly but surely started to assist with the 4th year program in tutorials as well as assessments and planning. And what started off as that small interest slowly but surely developed and led me to complete a postgraduate diploma in health professionals education, which was also through UCT. And I did this part-time over 2 years while still doing my usual clinical work and teaching work. And this was also during the COVID pandemic. So I completed the diploma cum laude in 2020 and have progressively become more involved in the neonatology program, and now co-convene the course with Dr. Rhoda and with incredible support from Leanne as well. And since then, we've also become, as Leanne has mentioned, honorary UCT lecturers, which has been really a great reward and for our ongoing contributions to the 4th year program. So along with building up my teaching and undergraduate education portfolios, I've also progressed in my own clinical career and capacity as a medical officer. I joined the community neonatal outreach team in December 2021, partnering with Leanne in the community outreach. So together we support one another in both community outreach clinics and in the 4th year teaching. And we aim to provide experienced neonatal care teaching within the communities, as well as to our future doctors that are coming up through the NBCHB program. And as we look to the future, like Leanne had mentioned, we are looking forward to having a publication in the next year, hopefully, and building on our experience in both the education and community platforms. Thank you.
Thanks, Michelle. And then last but not least, our latest addition, Dr. Kele.
Good morning, I'm Kele Korbani. I am the newly appointed neonates medical officer here at Mowbray. I'm also an aspiring pediatrician, but have struggled to get my way into the pediatric registrar program, despite having part 1's cum laude, DCH and DIP HIV. I'm so grateful for Mowbray's commitment to this initiative and allowing me the opportunity to work here, not only to continue my professional development, but to familiarize myself with the circuit, the Cape Town Metropole and neonate circuit, as well as more than anything, the mentorship. And I'm very excited for the year ahead.
So thanks, everyone. I just want to share a few more slides just to encapsulate what exactly the transformation plan was all about. So I'm going to share again with you. Find it. So those were our invisible, and I call them invisible because often people think that they're only the workhorses here, but they certainly have academic aspirations, as you've seen. And I've been fortunate to have these 3 goal-orientated doctors as part of our team. And as Leanne has said, the honorary lecture award that was given to both herself and to Michelle is really a way of the faculty and UCT and Red Cross saying, I see you and I appreciate you. And that does engender a very good spirit amongst the team. So they certainly demonstrate that a conscious decision to not pursue academic specialist training via registrarship does not mean that they do not have other academic aspirations. And what they need is an ongoing mentorship and an enabling environment to pursue and achieve their goals. And that's exactly what we have provided them with here. And as you can see, they've all blossomed. So my team and I wish to bring to the attention that, in fact, there are 7 other doctors with similar aspirations. But let us take you through our 5-year transformation plan, and we've come to the end of our 3rd year now. So the first 3 years really was, as Kele has shown, was to open up posts. So we've taken 2 permanent posts and put them into contract posts to allow more throughput of doctors who wish to go onto the circuit at Red Cross for pediatric registrarship. We've also assigned all the permanent medical officers a mentor. So each consultant, there are only 3 of us at Cruise here, each consultant takes on a 2-year rotation, 3 medical officers. We've also, in concurrent with that, allow better data systems within the hospital, and we've actually assigned a 4th medical officer to the VON database. And particularly also for the captive audience of medical officers here, we've wanted to support their personal growth as well. So from a funding point of view, we've asked them to choose 2 courses, one for the benefit of Mowbray and one for the benefit of themselves. And this has really been very useful because we're trying to see what careers we could possibly not push them, gently nudge them into. And one of those is the palliative care course, specifically for our patients who sometimes stay with us for very long times, especially the congenital abnormalities. So that's the end of the 3 years. Then for the next 4 years, which we will start in 2024 and 2025, we want to now grow the research component and just teach them the research basics with the final aim of actually allowing some publications. So what has happened so far? So to date, for the first 3 years, we funded GCP courses for all the medical officers. We've also funded courses for all the medical officers to improve the quality of care at Mowbray. We've sent one medical officer overseas to attend the VON Data Conference, and she will present once they have that going again. And so far, you've seen we've appointed 2 honorary lecturers. We aim then to provide the courses I've spoken about and to publish 4 articles, to attach 2 as first authors for the medical officers, and then also to attach 2 medical officers as co-supervisors for the research projects, whether those be part of MPhils, MMeds, or PG DIPs. And we can already see the early benefits. So Keely is one of the 2 rotational posts, so it answers both access and equity, and the appointments were in 2021 and 2023. We are now able, with better data that Nicole Meiring has done, to better benchmark care across high-income countries and certainly also within South Africa. We have started doing palliative care planning for all our chronic patients. And I think the colleagues have also alluded to now starting our first publication process, specifically in aid of how to set up neonatal high-risk clinics. So I think you will agree with me that they have certainly started blossoming, and that's very nice to see from our side. And we just aim to provide and strengthen the medical officers here at Mowbray with a defined career, and we will support their growth actively, because we firmly believe that transformation is an active process and no one should be left behind. Thank you very much. Ta-da!
Thank you so much, Natasha, and to your team as well.
Thank you.
Thanks, Natasha and Leanne and Michelle and Kelly. That was very insightful and nice to see you guys over Zoom. So we going to... Okay. So Curtis Care Hospital Neonatal Unit is where I work, and these happy faces are some members of the team, inclusive of all staff tiers from administrative staff to consultants. Our department is going to share 2 initiatives today. And in terms of the background for the mentorship program for medical officers, specialization in pediatrics is highly competitive, and neonatal experience is a fundamental prerequisite for registrar posts. Curtis Care Hospital is one of 2 tertiary neonatal units, and medical officers who apply to the unit do so on a contractual basis with the intention of gaining adequate neonatal exposure on their path to specializing. So the aim of the mentorship program is to career path medical officers from the moment that they enter our department to ensure that the year at Curtis Care is optimized and tailored to not only build their clinical skills, but to build character and resilience and provide the necessary mentorship and support in often neglected domains for young academics, such as research and publications. The mentorship is designed to not only address limitations in the clinical arena, but to appropriately guide junior doctors through aspects such as conflict with peers and communication difficulties, which often impede career growth more so than limitations in procedural skills. My undergraduate training is from WITS. However, I specialized at UCT, and I've worked at Curtis Care as a medical officer, a pediatric registrar, a senior registrar, a research assistant, and now as a consultant. And this is a process that I formalized when taking over the management of junior staff. However, the ethos behind this initiative was fostered in this very unit during my training by the consultants and the HOD that remain mentors but are now colleagues, and this is my way also of giving back. But who better to tell us about the program than the medical officers themselves? So I'm going to hand over now to our team of medical officers who are going to introduce themselves and take it over from here.
Good afternoon. I'm Charles, and I am a medical officer and soon to be a registrar starting in June. It is an honor to be part of a department that is dedicated to providing opportunities for career growth and development. And as someone who has benefited from the career supportive environment at MGN, I'm thrilled to share my experience with you. I like to think of MGN as a box of Smarties. We're a bunch of sweet people that are boxed together, but also our work environment is always colorful and fun. And every day is a different experience. And I'm very grateful for when I started here. It's a lot more than I bargained for. That's why I like to say what a lot I got.
Good afternoon, everyone. I'm Ilham Samaim, also one of the medical officers. At MGN Nursing, our consultants understand the importance of career planning and encouraging everyone to think about their career routes from the onset. MGN offers a variety of opportunities to grow and develop our skills that can boost our applications to specialized training posts. These opportunities are never mandatory, but are very beneficial for career pathing. It's important to note that these responsibilities should not impact the clinical care of our babies or any of our other responsibilities.
Good afternoon, everyone. My name's Abby Annell. I'm calling in from a separate location, but I'm also going to co-present this presentation. I hope everyone can hear me. I'd also just like to elaborate on some of the things that we do. So we have a diverse range of opportunities for career growth, including research audits closely supervised by the consultants, academic presentations on a Monday afternoon, teaching and roster organization, and the opportunity to join committees, all the while maintaining a good work-life balance and getting an incredible amount of support for any private academic ventures that we'd like to take on.
So I've realized before interviewing for a registrar post, it's good to keep a record of the procedures that we observe and perform. And it's essential to actually list these during the interviews. I think it really helped me to secure a specialty training post. The exposure at MGN gave me the confidence in PIC lines, inserting UVCs, applying CFMs and interpreting them, and also cranial ultrasounds. Also applying for registrar posts is quite a competitive process. And here at MGN, we are supported and prepared by consultants that aren't on the interview panel to ensure we perform very well during the interviews.
So teaching is an integral part of medical professionals' life, and we've been offered the opportunities to gain experience in teaching interns and developing leadership skills through teaching rosters and acting as leads for medical officers. So the teaching rosters for interns is structured and supervised. The days are chosen when all interns are able to attend. During this time, the other MOs cover our clinical areas as well as theatre, so that the interns all have the opportunity to have this uninterrupted educational time. And this where there's no interruptions to the clinical services as well. This is just a nice picture of some of our interns and medical officers during a recess start. We also have the opportunity, at MGN Nursery, we have an annual research day. So each medical officer is allocated a supervisor and an audit is performed. This topic can be potentially used for future MMed research. This helps us fulfill the research component when applying for specialized training posts. Some of our medical officers also assist consultants with data collection on separate projects with the aim of publishing in international journals. At MGN, we strike a good balance between clinical work, so that clinical work and research, so that clinical work is never affected.
Okay. And then, as mentioned, on Mondays, we do have academic meetings where a topic is selected and presented. A supervisor is usually allocated to the selected topic, and we do a thorough literature review and work closely with our supervisor before presenting on a Monday. This helps us with our academic research and presentation skills, as well as keeping up to date with the latest research information. We also have opportunities to join committees such as TAG. And as we have a meeting or an event, coming up on Wednesday, the 10th of May, a fun run in Constantia that we hope everyone can join in if you're able to join. In MGN, we make sure that we make time for fun and we function well as a team.
Thanks to our wonderful team of medical officers. Just to say, Abby's actually on leave and she's elected to pop in and say hi. So we appreciate that. And their colleague Cara is actually post-call. She had a very busy night last night. So she would have loved to be here, but she contributed to this presentation. So I think just before I hand over to my other colleagues and we talk about the second aspect, I just want to say this intervention is only successful because, as you can see, we lay down the foundation, but it takes motivation from an excellent team of junior doctors to actually execute it. And it's implementable because it's acceptable to both senior and junior staff. There's commitment from all senior clinicians in the department toward career pathing. And this initiative is not seen as additional work, but a responsibility that we have to our junior trainees to produce the change that we want to see. In addition, it's feasible because there's respect for the pathways related to governance, research ethics, with a clear distinction between clinical and research time in regards to patient responsibilities and care, which the juniors have clearly indicated through this presentation. And they understand that all the domains can be achieved in career planning while respecting peers, our patients, and which is important for junior academics to learn early in their career because there's a distinction between a career and a job. And we ensure that we audit and review this process continually at exit interviews with the interns and through active engagement with the medical officers to ensure we adapt as needed so that the overall output is not only measurable, but it's inclusive and remains beneficial to our junior trainees. So, so this is a we from the department, and as you can see with our Mowbray colleagues as well, it's interdepartmentally as well. There's quite a we and a collective togetherness. To add, so Charles is going to be a registrar very soon, and Ilam, Abby, and Cara are up next in the next set of interviews. So we hope they'll be on their path as well. So now I'm going to hand over to a colleague of mine who going to flick to the slide, who's going to just talk about the other initiative.
Hi, everyone. Just to talk about the other aspect, which was the academic financial support for neonatal nurses at Groote Schuur Neonatal Unit. And this has essentially been made possible through the Neonatal Nursery Fund, which is a fund ring-fenced within the Groote Schuur Hospital Facility Board Fund, which was initially intended to support equipment and operational needs. But in 2007, we secured a large donation to fund nursing education, noting that nurses are the backbone of the NICU, that motivation, morale, and respect are key, and that equipment is useless without the knowledge and without that support from them. So since that initial donation, the ethos of funding from the Neonatal Nursery Fund has changed, and we have funded the attendance of nurses at the Nils Bergman KMC education program, which was a huge endeavor. The perinatal education program also at Groote Schuur Hospital with 10 of our nurses attending a long program. Attendance at the International Nursing Conference. And most recently, and the topic of this most recent award is the sponsoring of the two nurses on the right. You can see in the picture there to get Muriel and Christine together with Sister Karen Michaels. So we sponsored Christine and Muriel to attend the full conference and the workshop. And the process of selection is entirely in the hands of the nursing manager, Karen Michaels, and then the selected candidates will send a motivation through to the fund manager, and then I will make a further motivation on their behalf to the facility board. And it's with this process that we intend to carry on supporting nursing staff to attend conferences and to make sure that they feel relevant and supported in their careers going forwards. Thank you.
Thanks. And Viva, that's it for me and my team. And again, we just want to thank you for the opportunity, and we hope to learn lots from our psychiatry colleagues up next. So thank you.
Thank you very much, Sakti, and to your team as well. I really appreciate the effort that both groups put into these presentations. So now we're going to move on to Claire from Psychiatry and Mental Health. I know she was traveling, so I'm not sure if she's back in her office yet. Oh, there she is. Thank you so much.
Thanks, Viwe, and hi, colleagues. Thank you for the opportunity for us to present, and thanks to my PEDS colleagues, I've definitely been inspired by what you've presented. And I just think, yeah, we've maybe got a bit of a different flavor because we're more research and capacity building, but I definitely see some very similar themes coming through. So I'm just going to share my screen. Okay, I'm just trusting someone's just going to chip in if my slides aren't showing properly. All right, so I'm presenting on behalf of CPMH staff and fellows and collaborators, both past and present, many, many people. So I'm just going to jump into it, and I'm going to give you a bit of an idea of what you're in for over the next 10 to 15 minutes. I'm going to tell you a little bit about our centre, just so that you know who we are and where we are. And I'm going to talk about why we need capacity building in this area and why it's important for us to develop a kind of pipeline for our staff. And I'm going to talk about a few projects that have been highlighted for this webinar. And then I'm going to talk a little bit about our capacity building model, or the way we like to see capacity building. Okay, so CPMH, sorry about this. CPMH is a joint centre in that it's a collaboration between us in the Department of Psychiatry and Mental Health at UCT and the Psychology Department at Stellenbosch University. And our vision is to be a collaborative, interinstitutional and multidisciplinary centre that conducts high-quality public mental health research and uses evidence for teaching, consultancy and advocacy to promote mental health in Africa. So to this end, we do a lot of capacity building, and we undertake high-quality research in a number of different areas in public mental health policy, services, legislation and human rights. We also advocate for the inclusion of mental health on health policy and development agendas in Africa. And we also participate in providing technical advisory services to provincial and national governments in African countries, as well as international agencies. So we've been a URC accredited research centre since 2014 on the UCT side, and we're also, as a centre, we're a WHO collaborating centre, and that's also been since 2014. And as from the 1st of May, we'll have 18 full-time staff, and we have 3 full-time PhD fellows, with 3 more joining us in the next 12 months. I just wanted to give you a quick overview. Our research covers quite a broad scope, from social determinants of mental health to mental health policy and services, measurements of mental health, and intervention, development, adaptation, and implementation. And we really do take a pipeline approach. I've mentioned the pipeline. We recently added a PGDIP program to our postgraduate offering. So that is our postgraduate part of the pipeline. But we don't believe it stops at PhD. As our colleagues have also been speaking about, that we really think beyond when it comes to careers. So we think to our postdoctoral fellows, we've had a couple in the past, and we think about our early career staff, and we're hoping that we move people through to become established academics and international research leaders. So in our programs, at any one time, we've got about 20 MPhils and between 6 and 10 PhD students. And we're very proud of our new PGDIP program, which has 7 PGDIP students at UCT, with 6 on the Stellenbosch side. And to date, we've had about 47 MPhil graduates, with a couple more, another 3 being added definitely this year. And we've graduated 9 PhDs, and we're very proud of Dr. Jacobs, one of our staff members, who's just finalizing her corrections at the moment. So I just want to reflect briefly on why we need capacity building. So definitely in research and health research generally, there's often a gap in low middle income country voices and also in low middle income country people taking the lead in research. And historically, we know that mental health has not really been prioritized, and global mental health or public mental health is a relatively new field, which in the past was largely driven from the global north. So there are large gaps in public mental health expertise in Africa, and we've witnessed an increasing demand for training. And within our centre, although historically our postgraduate students have been quite a diverse group, the composition is since 2012 has been about 70% Black African, 8% Black mixed race, 7% Indian and Asian, and 14% white across 11 different African countries. Despite that we have this diverse postgraduate group, in our centre, our staff and leadership, we are not as diverse as we would like. So we need an action plan. And this action plan is really building on systems and a culture and projects and programs that have been in place already. But we have added a couple of new projects. Okay, so now I'm going to give you a brief overview of a couple of the projects. The first one I want to talk about is the African Mental Health Research Initiative, or AMARI. AMARI is funded through the Wellcome Trust via the Deltas Initiative with the Science for Africa Foundation. And AMARI originally included South Africa, Zimbabwe, Malawi, and Ethiopia. And in AMARI 2, which has just started, Zambia and Ghana have also become part of the AMARI initiative. And we also partner with 2 UK research institutions. But this whole consortium is African-led. It's led by the University of Zimbabwe. So the main aim of AMARI is to build a critical mass of mental health researchers within an African-led network and really equip these researchers with high-quality research skills that meet the needs of their countries. And then another one of the aims of AMARI is to look at the career pipeline and to assist in building a sustainable career pipeline for the researchers that are being trained. And also to put the pieces together. I think when we think of academia and capacity building, we tend to focus, well, definitely from our side, we could probably focus on research skills or public mental health concepts. But there are other essential skills that really need to be part of the puzzle. So within AMARI, the Academic Competencies Enhancement Series was a key part of AMARI 1 and has definitely been improved for AMARI 2 and will go forward. So apart from training on research skills, there's also mentoring, career strategy, grant writing, engaging with policymakers, as well as work-life balance. We do laugh, and Tracy Naledi was there, that we had our work-life balance workshop, one of them on a Saturday, which was slightly ironic, but we recognized the fact, we were upfront about it. But we do also pay attention to those sort of skills and those sort of concepts for our trainees. One of the key parts of the AMARI ACEs was the peer mentoring. And I was an AMARI fellow, and I found this a very valuable part of training of how to be a mentee, as well as how to be a mentor. And this sort of approach can really be applied across different types of mentoring, senior mentoring, as well as peer mentoring. And I found this very helpful. And at CPMH, we do a lot of informal mentoring. I think that's kind of baked into what we do. But sometimes a formal approach can also be helpful, and specifically for some people who do like the more structured approach. So that was AMARI. I'm hopping over to the Sue Stringman Initiative. And this is a partnership with the Andreas and Sue Stringman Foundation. And the purpose of this initiative, which started in 2020, is to address the mental health implications of childhood and adolescent adversity and trauma by providing a base for research, capacity building, and policy development. And this initiative seeks to ensure the provision of high-quality interventions for the prevention and treatment of mental health problems among this adolescent group. So the initiative funds 2 fellows every 4 years. We've designed that there's a year overlap. Our first 2 PhD fellows are in process, and it's really been key and wonderful to see how they support each other. So both of these PhD fellows are South African women, one of whom is a Black South African woman, and they are focusing on mental health interventions for 10 to 14-year-olds in the one project and 15 to 18-year-olds for the other. They're both working in schools, and Miriam Mkize is focusing on adapting and testing the World Health Organization early adolescent skills for emotions intervention. And our other fellow, Chesney Ward-Smith, is looking at adapting and testing an emotion regulation with the older group. Sorry, emotion regulation intervention with the older group. And their projects are progressing really nicely, and we're excited about their developments. And part of the initiative is a youth development team. So this is kind of like an adolescent advisory board that will be an ongoing, it's not linked to a specific project in a specific research project that will end. This is an ongoing initiative. And this youth development team will advise us on research priorities, research projects, interventions. And we've had a couple of meetings so far, and they're more like parties. The youth are wonderful. They're between the ages of 12 and 18, and they come from different communities across Cape Town. And they've really provided some amazing inputs and surprised us quite a few times. We thought we know what we're doing in this one little area, and the adolescents come and just turn it on its head, which is really wonderful. So we've really enjoyed this aspect of it. And my colleague, Gillian Hanslow, who's on the call right now, is very much a key part of the Sue Stringman initiative. Okay, so now I want to quickly mention one of these fellows, Miriam Mkize, was selected for the Accelerated Transformation of the Academic Program Initiative. And this is a UCT program. This is not something that we came up with at all, but the program focuses on Black South African candidates, and the purpose is to retain these candidates in academia and prepare them for senior positions. So they are providing extra training and support and career development, which is amazing. And it just really aligns with our priorities and the way we really enjoy doing things. So we're incredibly proud of Miriam Mkize. She has great leadership potential. We're hoping to retain her, and I'm very looking forward to celebrating Prof. Mkize one day. So the next, I'm hopping over to another project. This is the African Mental Health Researchers Inspired and Equipped Initiative. It's a D43 Fogarty International 5-year capacity building grant. And we have a few objectives within Program Arise. So the first one is deliver and evaluating our new postgraduate diploma program in public mental health, which is, the first cohort is well on their way at the moment. So it's going very well with that. We also want to train masters and PhD students to conduct public mental health research relevant for their setting. And we're really looking at integrating their work with community organizations and broader projects. And so we are very proud of Nama Kawita Moshani, who is our PhD student on the UCT side. This is, again, a collaboration with Stellenbosch within CPMH. And we've got Claudia Swinney is the other PhD fellow, and she's right in the center of this photo here, and she's a Stellenbosch fellow. And these PhD fellowships were really built in to intentionally build academic CVs and academic skills for people who would really love to stay in academia. So they do receive training in teaching, they interact with our fellows, while they're also doing their PhD and learning public mental health concepts and skills. So Noma she completed her MPhil with us, and she's now moved on to a PhD, so it's lovely to see that progression. And also within Arise, we have the staff component is we also want to strengthen our teaching and mentoring skills and student supervision skills. So not only within UCT and Stellenbosch, but within our broader ARISE faculty, which includes academics from a number of different universities in other African countries, including Malawi, Zimbabwe, Nigeria, and Ghana. So one of our posts that is part of ARISE is that of a lecturer post. And this is also, we intentionally designed this as a transformation post for someone who wants to remain in academia and develop their skills. And we had some really great candidates, and we're very proud of Shahima Ali, who is our lecturer, and I know she's will go on to a PhD, and I'm very much looking forward as well to having Prof. Mushani and Prof. Ali still in our centre. Another part of ARISE is to implement and evaluate some short courses for people from diverse disciplines. So we're thinking implementation science and theory of change courses and the like. So I just want to tell you a little bit more about ARISE and the fact that the whole, it's an African network, the faculty, and we intentionally pulled together a diverse faculty with regard to nationality, ethnicity, discipline, and level of experience. So we have early career, we have more established researchers and academics. There are 5 African countries represented, and a range of expertise. So we have lived experience expertise, psychiatry, health psychology, nursing, physiotherapy, occupational therapy, social work. So it's a very exciting initiative, and we're really enjoying the interaction. And I'm very also excited about the development because 2 of the Amari PhD fellows from past cohorts have completed their PhDs, and they're now on the ARISE faculty. So that just really illustrates the development and the way we view the capacity building, and also our colleagues in our networks also view the pipeline idea and developing people in their careers. So we're very excited about that. So those are the projects that were identified for this webinar. But I just want to bring it all together by just talking about I like to call it the African social ecological model of capacity building. And as I mentioned at the start, there was already a culture and a system in place. And a lot of what we do is baked into this model. And also we also intentionally go after outcomes and factors at these different levels. So I want to talk about just the broader field. When it comes to our staff and our early career staff and our fellows, it's all about introducing them to the broader field of global mental health. So we're positioning people to be international research leaders. And we also look at our African networks from past projects, as well as from Amari and ARISE, that we really are developing connections and collaborations within Africa, and also introducing our fellows and early career staff to PIs from African institutions that are leading important work. So we feel that that is incredibly important. And then within UCT and the Department of Psychiatry and our center, the institutional resources, the vibrant research culture is really key. And we really feel that is a vital part of this model. And our Sue Strungman initiative fits in into this area as well. And within our center, we also look at for our early career staff initiatives such as mentoring people in being postgraduate supervisors. So for our MPhil and PhD students, we'll have a senior supervisor and then a junior supervisor that work as a team. And so the junior supervisors will learn by doing. And so they're not only mentored in their research and their career, but also in providing effective and supportive postgraduate supervision. And we also provide teaching opportunities for early career staff. And I also want to say, just mention here that from a past staff perspective, they are a very, very key part. We've got Gillian Hanslow on the call. We've got Sungalwa Mobo, who's also part of our centre. And we really view the whole team as being a cohesive team. So it's also about those really key resources. So then when it comes to, and I think within the centre, we've been building a culture of respect and supporting each other, and also trying to draw in different disciplines. With the new PGDIP, we intentionally targeted disciplines that are underrepresented in global mental health, such as social work and occupational therapy. And also within people, we really feel it's key to connect people, that people have role models, and that we also peer mentoring is part of what we do, often in a more informal way. So our people are obviously very close to our heart. So, I mean, we often hear the saying that it takes a village to raise a child, but it really does take a system to raise an academic. And our colleagues in PEDS highlighted this. And I think I'm just saying the same thing along the same theme. And we also strongly believe it takes Ubuntu values of reciprocity, trust, shared responsibility, accountability, inclusivity. So we really feel that all these are key parts of what we do at CPMH and also within our broader networks. So in conclusion, there's a need for inclusive public mental health research and evidence-based practice in Africa. There's a need for African innovation to feed into global mental health and what people do in other countries. It does require a complete pipeline to transform the field and also transform higher education and our centre. We do experience challenges in achieving our goals. As a number of people do, we are a self-funded centre, so we're building our pipeline and we're very excited about our people, but sometimes I wonder who we're building the pipeline for. Yes, I'm the broader field and higher education in South Africa and Africa. It's great if we can develop and assist in all those ways. But I really also want to build the pipeline for our centre and see our centre grow from strength to strength. So on self-funded research money, that can be challenging. But it's also amazing that we are building a network of dedicated public mental health researchers and practitioners. And every new group of postgraduate students, and now with our PG DIPs, I'm really excited to see these networks just growing and growing. And obviously this has gone on from, this is far, far bigger than just these projects we're doing now. It's people like Alan Flischer, Craig Lund, Catherine Sorsdahl, who've been involved in developing these and been doing really amazing work in bringing people together and conducting high quality research and capacity building. So I really, again, want to acknowledge all the people. And yeah, I'm very happy to take questions or comments. I think we have a general Q&A session. I just want to say I'm all ears.
Thank you so much, Claire, for that amazing presentation. Yeah, as Claire said, we have a short Q&A session now. So if you want to ask her any questions or ask Shakti or Natasha's groups any questions, now is the time. Please feel free to also just put some questions in the chat if you don't necessarily want to put your hand up and speak through your mic. Thank you so much. You can go ahead, Steve.
Yeah, I have to speak because I can't chat. I haven't got a chat function. But what fantastic presentations. Thank you, guys. And I particularly want to commend those who are not used to presenting. And I appreciated your participative way of presenting. A comment for all presenters, really. But Natasha's group specifically, the Mowbray group specifically highlighted the role of the sort of career MO and making it actually a really interesting option for people who don't necessarily want to specialize, and particularly people who don't want necessarily a full-time job and want to have a life outside of medicine as well. And this thing of the need to specialize and to dedicate yourself to this incredible career, research or otherwise, it's not for everybody. And I just wanted to reflect on the idea of not just career MOs, but the part-time options that need to be available to people who still want to have an interest in research or in teaching, but not necessarily like full-time 150% like most of us feel trapped into. So not all roads lead to specialization, and not all roads lead to full-time, hectic medical careers. But what amazing presentations. Thank you.
Thank you, Steve. If there are no other quick, I think there's another hand up. But perhaps I also just want to say the unique, and it's not only at Mowbray, you're fully aware, Steve, in the rural areas, a lot of these are also women and mothers, and they have chosen, and that's why I mentioned it was an active choice not to pursue the registrarship specialization, but it doesn't mean that they don't have academic aspirations. And I think that's very true for 9 out of the 9 women and mothers who work in this particular hospital, but across the country. And if I could just also punt for job sharing, it's really something that we are lacking. We're way behind the curve for other high income countries. We've got a lot of people who, by choice, wish to work and be mothers.
Yeah.
And we're not offering them that choice. We're not making it possible. We've tried. I've certainly tried for 15 years at the highest level, and there's always a block. And I think collectively as academics, to increase our pool, there's so many of us that can be drawn into the fold if we actually have better choices available, and those choices aren't available to us yet.
There's a published article from George Hospital about the job sharing thing, where they have a very proactive a CEO and clinical manager who made that possible. But yeah, it's not just mothers, fathers too.
Fathers too, absolutely. I happen to have a group of mothers.
Thank you so much for that contribution, Steve. Lionel, I see your hand is up.
Yeah, thank you very much. I mean, these are fast becoming the highlight of my diary, and I'm sorry that I wasn't here at the beginning, but I really want to echo what Steve says about the nature of these presentations. I did want to ask a question. I think it was from your presentation, Claire, because one of the things that struck me about your presentations is the merging of mentorship, learning, and choosing the path. But Claire, you left one question hanging, and in the social accountability framing that I think about things through, you ask the question of who is this for, and then answer the question that you really want your center to grow, and then the nature of the educational opportunities for in PEDS thing that I came in just in time to hear. I wonder in that this is part of the transformative conversation. One, I want to ask you, Claire, directly, who's doing the teaching for your teachers? Who's preparing them for the teacher role? And how is that structured? But just generally, how are we defining that kind of question? For whom is all of this for? Is it for individuals and their careers? Is it because this is the best way to deliver care? Well, what do we eventually say is the end point for all of this? But I have to say that it's prefaced really by being quite struck that this is happening here in our faculty, and there are only 30 of us hearing these stories. Thanks.
Thanks, Prof. Yeah, who is this for? I mean, I definitely Love the idea. I mean, if I'm training people and they're going to go out and make an impact somewhere else, and we do up and train clinicians who want to, I mean, I came from a clinical background myself, and I kind of understand they want to still be clinicians, but they do take a researcher mindset and some skills back to wherever they are working. So I think that is wonderful. But I just think, you know, you get to know your people, and we're incredibly proud of them. And I can just see the projects they can be involved in, and you know, we just don't want to lose. We don't want to lose them. But I think a lot of our trainees in our postgrad programs, we've had some NGO staff, some policymakers. We have a lot of clinicians, which for me is very exciting, because I think some of the best research questions come from the clinical space. And I definitely can think back to my clinical days and think, yes, there's a few things I could have researched there. So that's really exciting. When we talk about preparing people for teaching, I mean, I think this is also very much a health sciences thing, if that we learn by doing. So a lot of it is learning by doing, but observing each other and giving each other input. But we also bring in external people to help training. So we've had someone come in to train us on postgraduate student supervision, which is really lovely. So we got a bit of the theoretical background to postgraduate student supervision as well as some practical tips, which was great. We've worked closely with SILT at UCT. They're helping us build our PGDIP and the website on Amatuba. And so we're all being trained in that. And our PhD fellows and early career people have also been trained in that. And they've been giving us workshops on, you know, training in the online space. And so quite a few of us in our center, as well as people in our networks, have benefited from those. So a lot of us, yeah, we don't have training in being a teacher. So we do our best, and then we bring in experts to supplement the training. I hope I've answered your questions, Prof.
Thank you so much for that, Lionel. Tracy, I see your hand is up.
Unmute, Tracy.
Skis. So like everybody else, I first want to just offer my just inspiration, you know, like I'm just so inspired to hear the work that is happening, and grateful for Viewer for creating this platform for all of us to hear all of this wonderful work. When I listen, however, I see that this takes a lot of work from individuals who are doing it because they believe in it. When I listen to everybody who, particularly the champions, Ellen, Natasha, Claire, and others that we've listened to, I get a sense that they're dedicated individuals who feel very strongly about this. So my question is, how do we make it beyond the people who feel strongly about mentorship? How do we I mean, you've done it. So if I had to ask you, what would have made what you've done easier as we think about how to create an environment where this can be a no-brainer for most people? I loved your kind of ecological approach, Claire, and kind of takes the whole village and thinking about that. But I mean, you've got the dean here, you've got a whole lot of people from the faculty, Karen, Nave, and a whole lot of us here. What do you want to tell us? How can we support something like this being beyond just a few people, good people who are doing this? How can their wonderful experience at MMH and other places be felt by everybody who is a UCT staff member or who works closely with us on the platform?
I think I guess if I could give a go, if you don't mind, Claire, and Shakti or Alan. So it's not an easy answer, because I think what we probably share is a common ethos And that ethos is that we want to see the greater good within the communities that we serve. So ultimately, who are we serving? We are facilitating these young people, young doctors or aspiring pediatricians to ensure that they become part of a system where the care and everything that goes with holistic care is clear to them, that it's not about the individual. So it's a bit philosophical, but the greater good is what's at stake here. And for me, I speak for myself only, it's always been part of my ethos that part of what I do must be for the greater good. And so this becomes part of that, because they will extend that greater good if you teach them that. So it's that ethos. And so it's really difficult, because how do you give someone a different ethos to what they have? So it's an interesting question. It's not a simple answer. And I guess what's going to happen is it's a drop. So we are all drops, and it's in a pond, and we hope that will ripple. But if you're asking for an accelerated process, unfortunately, it's going to come from the leadership from your side. So it's top and bottom. So we are the examples. You continue pushing. And there will come a point where you get a critical point where if you don't do this, you will be the outlier. At the moment, we are the stars, whatever you want to call it, champions. But when you get to a point where 60% of people are doing this and the 40% who are not doing it will be it'll be quite obvious that they need to come on board, or, be told to come on board. So I don't think we're there yet, but we're slow. It's certainly different to what it was 10 years ago. Me sitting here in this position, telling you about these amazing people who've actually been in the system for 10 years already, you've never heard of them. And so the blank slide I gave you on the invisible and the aspiring, they should become visible. And this is a process to make them visible. And you've honored them by making them visible, because I said to the aspiring pediatrician, does she know anybody, does she know Prof. Malua? And she said, no. I said, but you do know, because he knows you know. And I think that's what it's about. And this is the process to do that in many other ways. And we're just happy that it's been noticed, not for me, for them. Because otherwise they will, continue being here for 20 years. She's been here for a decade. She's been here for a decade. She's been in the system now for at least 6 or 7 years. Probably doesn't answer, but it just talks around.
So can I chip in? First, Tracy, I think that was an excellent question. I think you made us all stop and really think about it. And I think for me, that's also part of wanting to retain some of the people we train. I was trained by Catherine Sorsdahl, who's got a lovely policy of bringing people along. So even when I knew nothing, she took me along to meetings. I met people I learned by hearing and doing. So I am now taking others along. So for me, that's part of the argument, to try and retain some of our people as some of that culture. And also, our PEDS colleagues also mentioned things like exit interviews, which we're trying to maybe formalize that process of part of an exit interview is, what could we have done better? Or a transition interview, if people are going into another post, what could we have done better to develop you in your career? And we're starting at the moment, we're reviewing all that in our center to do induction and exit interviews and make it a standard thing. And that's just what we do. So that might be one way. But I do, Tracy, as you were speaking, it makes me want to go back to the implementation science literature where they talk about a learning culture and how an organization develops this learning culture. So I'm pretty sure there's some evidence-based strategies we can take from there as well.
Alan, your sense?
Yes, thanks, Tracy, and everyone. Shakti should be speaking now, but she's just had to step out to ICU. But as the older and grayer one, looking back at since Shakti's taken over the mentorship of our medical officers, what I have seen is this reaching in both directions, both to the medical officers and to the senior staff. So almost like a de-siloing effect. try and engage and get everyone to buy in or to appreciate the need for career pathing and really just to really build the team and to see the whole concept of doing things as a united and not as silos. In terms of taking it forwards, you know, we do have tools, but such as our SPMS forms, which is a provincial tool, and one wants to avoid duplication, but there could be some merit in putting a bit more emphasis on the university aspect of our joint appointments and having some sort of reflection on that process. There are formal structures, but generally people see it, to be quite honest, as a lot more rubber stamping, and perhaps we can pull out some aspects of those. But thanks for being part of this forum.
Thank you very much. Dan, I see you also have a hand. Is it to this, or I must hand over to Viwe? I'm taking over. Sorry, Viwe.
No, that's good, Tracy. Yes, I think your question is really excellent. I mean, just to preface, congratulations to all the presenters. As others have said, it was really spectacular and inspirational. But I think Tracy does ask the right question of how does one replicate this? Because, you know, I don't know how representative this group is of our broader faculty. I mean, hopefully it is quite representative, but it may not. There's a risk that it may not be. And it was just a quick sort of thing that I'm not 100% sure how well, and also looking at the people on the call today, how well aware undergraduates across the professions are aware of the people that we've heard of today. I mean, I don't think that I, as a medical student, really got a sense of the opportunities of a career like the one that Claire or Kat Sorsdahl has. And in fact, even as a specialist, I didn't really have a very good sense of this. It was really only when I had a mentor as a post-specialist, postdoctoral fellow that I started to think, so this is how it works. You mentor me and this is what happens, and then I can do that, I can do that, I can do that, and then I can mentor someone else. Took me forever to work hard. I mean, I'm still working hard, to be honest, but it really could have started a lot earlier. Thanks.
Thank you, colleagues. Viwe, over to you. Sorry for taking over.
No, it's not a problem at all. Yeah, I think just one last round to check if there's any questions. Otherwise, if there aren't any, I think, okay, one more. Thank you, Lionel. You can go ahead.
Sorry, I'm really asking this question because, again, it's drawing from Tracy's question. And for me, I'm asking about the so what of this moment. Because these stories emerge from the fact that we report on events in departments that demonstrate our transformative activity. And so I'm trying to ask, Tracy was asking it, what you want from us. But I wonder if the question is not, and linked to Dan's comment just now, is how. So there's a sense of two groups which are experiencing high levels of inclusion and engagement. Three, I think it is. Three groups which are experiencing high levels of inclusion and development. And I'm also mindful that there's an ongoing narrative in the faculty of exclusion and alienation. So how big is this, and what is the impact? I mean, I know, and what is the so what for the faculty? So as I leave these always, and I was quite struck at the previous one as well, I leave the sessions trying to work out for myself and for this leadership team, so what? How do we translate it? Can we scale these things? There are only 30 people in the room, and it strikes me that many people have come because of their association with these programs. How do we translate this into a faculty culture? Because my sense is that that's expected of us. but I'm interested in the environments that you occupy, about how we change the faculty culture. I mean, we, for instance, in the process of rewriting the add-on criteria to foreground transformative activity. But yeah, what did you think we should be doing in the faculty? Does this just depend on the individuals who initiate this, as Tracy was referring to? What do we need for scale, in your opinion, from these? What are the things that you see that if the faculty did differently, these things could be scaled to different levels? Maybe it's too soon to ask, because I think this has really been a celebratory moment. And I'm asking for what work needs to be done.
Thanks, Prof. I'm just going to jump in. Yeah, there's obviously, it's a very broad question, and a lot of thinking needs to be done, but I'm just thinking of any low-hanging fruit. So if we have any training on mentoring or the GROW model and how to think about career development, you know, it would be lots of fun. I really enjoyed different disciplines coming together. So if that's something that could just, yeah, if we do a training like that and we throw it open to other people from the faculty, that might just start a conversation. That's just off the top of my head, something that could be done quite easily.
I think, Lionel, if I can also maybe add to that response, that would be a really nice question to ask at the last webinar, when we've gone through all of the benchmarks and we've seen what all of the departments have been doing under the different benchmarks of the report. And I think especially because at that time, it'll also be close to when not just the faculty, but the different departments are also doing their strategic planning for the following year. I think it'll be a nice question to ask, just to make us think about reflecting on what we've heard throughout this year, which parts of those presentations can be implemented in different spaces, which parts of them can be streamlined, like you say, broader across the faculty, but also just which parts can we pump more resources into, whether it's cross-department collaborations or whatever the case might be. Yeah, I think it'll be a very nice question to circle back to when we get to the very last webinar. Dan, I see your hand went up again.
Yeah, thanks for the opportunity again. So again, I think Lionel's a great question. I want to mention two things as someone who's an insider, outsider. I'm outside the Department of Pediatrics, and what I think pediatrics has is at different hospitals, I mean, Mowbray Maternity, Groote Red Cross, is just a culture of mentorship that I'm not sure we have in all departments. I'm not sure everyone feels it necessarily in those three places. But from today's presentation, it seems like people do. You know, like training of nurses at Red Cross. We don't have that in other departments. So I think it is partly dependent, or at least in my department. So it is partly dependent on the culture that Province creates, our partners. And then the second thing I want to say is within our department, as an insider, there were a couple of things that were really useful for the development of the Division of Public Mental Health. And one of them was a business plan. So at one point in the faculty, we didn't have business plans. And really what allowed us to retain CAT was a business plan. We weren't able to retain CRIC, and I think we need to be more flexible on our feet sometimes to retain excellent mentors. And then from the division itself, for me, the most key thing is that as researchers, what they do is they build into their research grants teaching and mentorship. That is not something every researcher does. And I think by doing that strategically, that's really allowed them to excel, in my view. Thanks.
Thank you, Dan. I think it's Lionel's hand. Oh, Rosanni, you can go ahead.
I'm trying to see if I can get my camera. I can, right? And I know I look a bit like a Christmas tree. Can you hear me?
Yes, we can see you and we can hear you.
Yeah.
At least you're a happy Christmas tree.
So I wanted to say, look, it's really been great and very inspirational hearing the inputs, both from our department as well as from psychiatry. One thing that I just found very interesting, which has been a major issue for me, is this notion that of how we move from seeing what we do as managing projects in very technical terms in such a way that the human element is usually lost. So when we're looking at, for example, the example of Mowbray, for example, where you look at career medical officers, for example, one thing that I think has always happened is because a number of medical officers have been seen as pretty much like tools for getting some job done. And this happens throughout the whole system in terms of even how sometimes registrars feel and interns feel. And because I meet with people in this respective area, that's how they feel. But if we start seeing the workspace as part of the broader life experience and see people as people, and our response create or are created and held within that human kind of and humane kind of gestures, where we see people and their work as a continuum of life. As I always say, when you are having a miserable time as a medical officer or an intern or a registrar, it's not your work-life suffering. That is just your life suffering. There is no this demarcation of work and life is completely artificial. Your life suffers. So when you start seeing people in the broader perspective, and that's what I know we try to do. When I was at Groote Schuur, for example, which is why I think Dan mentioned that people have got different mentoring. It happens all over. We try to figure out how can we make sure that medical officers, in that case women, who have decided that at this stage of their careers and their lives, they want to be mothers who are available for their children. But they should not necessarily be seen as sacrificing growth and development. You don't even have to call it academic. It's just growth and development. One day their children will go to high school. They may need not to be as present in the form in which they are today. But what they do in the meantime is building capacity into their lives so they can take other opportunities going forward. So, for example, we've made sure that the ones that we have done, like going to do an MSc, someone is finishing an MPH. In fact, they've both finished a master's, and they're thinking, can I still use the space to do a PhD or do something that means I grow, I develop within this space? That is their life developing. And I think we need to create these spaces where we don't necessarily only give technical responses of what we do. We need to ask questions about whether what we do is meaningfully investing into human life and into people in a way that enrich their lives and reciprocally get that richness back in. When people come into our spaces at the university, at work, what they do, they draw from the bank of their lives. And we need to also learn to make meaningful contribution to that bank, than make a workspace and net withdrawer with minimal input into that space. So it's just something that for me has been a major worry of not managing people as project, but as seeing our spaces as the broader space of life. And the transformation we need is creating a whole human space, which is different in terms of how it sees people and how it values them. So that is just my take with this. Thank you.
I don't want to put my hand up a third time, but I just want to very quickly take the opportunity to thank Ridzani for the Sue Stringman initiative at Public Mental Health. So Ridzani is not just talking the talk, he's walking the walk. He's really actually moved things forward by doing what he's suggesting.
Thank you so much for that, Dan. I think on that note, we can conclude today's webinar. This truly has been, I think, one of my favorites. It's only been the third one, but it's been an amazing afternoon. The presentations were great, and thank you so much to everyone who came to support and for the conversation at the end of the presentations. I wish you all a very nice afternoon and a very nice evening, and I will hopefully see you at the next one. Thank you so much.
Thank you, everyone. Bye-bye.
Thanks, everyone. Bye.
Thank you.
Thank you.
Thanks, everyone.